Good afternoon. My name is Anett and my thesis is the invisible presence of microscopic colitis. I'm a first-year PhD student in the group of gastroenterology and endocrinology of the CTM, and I am also part of a 12-month fellowship program provided by the MOL Foundation for the Community. In my vision, there are vigilant physicians who educate patients to prevent the development of the disease, microscopic colitis, and for that my mission is to provide professional knowledge about the clinically relevant risk factors of microscopic colitis. I have two ongoing projects. My first topic, microscopic colitis, is a risk factor for low bone density, which we managed to finalize and submit it to the D1 journal Elementary Pharmacology and Therapeutics. And right now the status of the manuscript is awaiting for reviewers. Just a few words about the background. In Europe, the prevalence of microscopic colitis is around 119 cases per 100,000 persons. There are many confounding factors regarding the relationship of microscopic colitis with low bone density. First of all, both diseases are more frequent in elderly women, and furthermore, women in menopause can get hormonal substitution treatment, which in turn can cause microscopic colitis. Moreover, budesonide, the gold standard therapy of microscopic colitis, is a corticosteroid with low systemic bioavailability due to its high first-pass effect in the liver, but still it has been implicated in a long-term therapy with the development of low bone density. So our aim is to scrutinize if microscopic colitis is a risk factor in the development of low bone density. Our clinical question was if MC is a risk factor for developing bone mineral changes, and we applied the PECO and the COCOPOP frameworks. We made our systematic search on the 16th of October 2021 in 5 major databases with the search key of microscopic colitis and the 3 subtypes of it, while the second part of the search key referred to osteoporosis and the synonyms of it. During our search, we got around 3,000 hits, and the number of included studies in this analysis was 4. Our first outcome is if MC is a risk factor for low bone density. We analyzed microscopic colitis patients with low bone density in comparison to age and sex matched controls with low bone density. The I-square was 48% with a moderate heterogeneity due to the Rancz study, which has a cross-sectional study design with the youngest and the smallest population, and in which not just MC patients, but with Crohn's disease patients are investigated as well. Our effect measurement, the odds ratio is 2.96, and it means that microscopic colitis triples the risk of low bone density. In our proportional analysis, we investigated the different bone mineral changes in the MC population. Low bone density has 2 forms. The mild is osteopenia, and the severe form is osteoporosis. Its clinical importance is that osteoporosis can culminate into osteoporotic fractures. So our first analysis is the proportion of LBD in microscopic colitis patients with considerable heterogeneity of 75% due to the Greenberg study, which was a conference abstract with female predominance. The proportion was 0.68, which means that almost 2/3 of the patients have low bone density. Our second investigation was the proportion of osteopenia in MC patients, and it was 0.51, which means that half of the microscopic colitis population has osteopenia. And our last analysis was the proportion of osteoporosis in the microscopic colitis population, with a proportion of 0.11, which means that 1 in 10 microscopic colitis patients has osteoporosis. And all of our outcomes are at very low level on the certainty of evidence following the GREAT PRO guideline because of the small sample sizes and because they use a surrogate outcome measuring the bone mineral density. The strength of our study is that this is the first meta-analytical association between LBD and microscopic colitis. And all the studies use the DEXA to measure bone mineral density, and we applied a robust methodology. On the other hand, we have some limitation, like a low number of studies with different study designs and a small number of patients with a female predominance. So as a summary, the odds of developing LBD is tripled in the presence of MC, and the proportions of low bone density is 68, of osteopenia is 51, and of osteoporosis is 11% in the microscopic colitis population. In conclusion, our data suggest screening patients with microscopic colitis for bone mineral density at the moment of diagnosis. Based on our findings, we recommend lifestyle and dietary changes in osteopenia, calcium and vitamin D supplementation, and we also recommend impact exercise combined with resistance training because it was shown that this fits the best for pre- and postmenopausal women to maintain their bone mineral density. As regards of implications for research, we need further prospective observational studies and incidence studies to elucidate the fracture risk, and we would like to highlight the importance of international and national registries with bone mineral density follow-ups. My second topic, risk factors of microscopic colitis. In Europe, the incidence of microscopic colitis is around 11.4 cases per 100,000 person years. Medication use has been implicated in the development of microscopic colitis, while body mass index is inversely associated with the risk of microscopic colitis. So our aim is to assess the risk factors of MC adult patients. Our clinical question, what are these risk factors of microscopic colitis in adult patients? And we applied the PEO framework. And our hypothesis is that in the presence of the risk factor, the odds of developing microscopic colitis are higher. The clinical implication is screening and prevention. We made our systematic search on the 18th of December 2021 with the search key what contained only microscopic colitis and the 3 subtypes of it. We made our search in 3 databases, and right now we are ready with data extraction and the risk of bias assessment for 43 articles, but we still have to analyze if these articles report on the same population. My goal is to submit my second project during summertime, and I would like to close my presentation with the following words: there are no shortcuts to any place worth going. Thank you, and if anyone has questions, I'm glad to respond.
Thank you, Anett, for the presentation. I have a question regarding the first project. You included 4 studies at the end. Did they mention the subtypes of microscopic colitis? Like any of the studies only investigated, for example, collagenous colitis or lymphocytic colitis alone? Or was the population microscopic colitis in general?
They mentioned the subtypes of it in numbers, but they didn't report the numbers of, for example, low bone density patients in this MC population.
Okay, thank you.
I personally really like this topic on microscopic colitis because the knowledge about microscopic colitis is much more or less than in the IBD. As we know, in the IBD, there is a quite intense research about D vitamin. Does this your analysis maybe shown some some vitamin D supplements or vitamin D levels in this patient, if there is maybe any difference?
In one article, they are mentioning that, but we didn't have enough data to make analysis regarding this.
Thank you.
How about the onset of the disease or the disease length? Whether is it influencing the bone mineral density? Do you have data about that? That how long the patient are carrying the diagnosis after these were investigated?
In this analysis, they were only those patients were investigated who had available DEXA measurements. So they didn't have, so no prior diagnosis of low bone density was allowed.
But I mean the diagnosis of microscopic colitis, how long the disease is carry on, and whether is it affecting the bone mineral density?
For this, we don't have data.
Thank you for your nice presentation. I'm not sure if I got it right, but the Rancz et al. Study has a mixed population, if I got it right, with microscopic colitis and IBD, if I'm... So my question would be that isn't it a bias in your plot because you were using like 3 or 4 different studies, or what is the ratio of microscopic colitis patients in that study?
In that specific study, they are investigating microscopic colitis in comparison to healthy controls, and they are investigating as well Crohn's disease patients compared to the same healthy control sample. Its importance is that microscopic colitis is more frequent in elderly women, while the Crohn's disease is more frequent in younger patients. So the control patients, since it was age and sex matched controls, they got the youngest population in that analysis. And it was only like a cross-sectional study.
But your results were mixed with in the microscopic colitis group with IBD and microscopic.
They are not the same patient group. So we have the microscopic colitis patients compared to healthy controls, and we got the Crohn's disease patients compared to the same sample of healthy control group.
Okay, thank you.